For this week's module, I took a look at non-ventilator hospital-acquired pneumonia, or NV-HAP, in an article titled Oral Care as Prevention for Non-Ventilator Hospital-Acquired Pneumonia, a 4-unit cluster randomized study. The CDC reports that HAP is the most common acquired infection in hospitals. HAP represents 26% of all hospital-acquired infections, and non-ventilator HAP represents 65% of the cases of HAP. Non-ventilator HAP is largely preventable compared to other HAI infections. It comes with increased mortality, increased length of stay, ICU utilization, and costs higher than other HAPs, other than ventilator HAPs. And the risk of death is 15.6% versus 1.6% for other hospitalized patients. And research has proven quite a bit lately that the most modifiable factor has been oral care. As far as the pathogenesis of NV-HAP, research has shown that within 48 hours of admission to a hospital, oral bacteria in people's mouths changes and new bacteria are colonized into the dental plaque. Virulent strains of organisms found in oral microbiota changes to include Staph aureus, Klebsiella pneumoniae, Enterococcus cocci, and Pseudomonas aeruginosa. These organisms in the dental plaque can be aspirated into the lungs, and when aspirated into the lungs, it triggers inflammation. Improved cleaning of the biofilm proves to be the primary source control for preventing HAP pathogens and infections. The study hypothesis included an expectation that there would be a significant decrease in the incidence of NV-HAPs. Other studies have shown the benefits of this intervention, and they were optimistic in their expectations. It was a 12-month study. They enrolled over 8,000 participants, and it was conducted on 4 separate units of an 800-bed tertiary care hospital. The study reported statistically clinically significant results on the medical intervention unit. In fact, patients on the control medical unit were 7 times more likely to develop an infection than those on the intervention unit. And patients who were on this unit went from getting 0.95 times to 2.25 times of oral care a day, which was pretty good, but an extraordinary reduction of 85% in the incidence of NV-HAPs. More dependent patients were on these units, and shorter length of stay was recorded. The odds of developing an NV-HAP on the surgical unit were without significance. Unfortunately, they did not get enough patients to power the study, but even so, patients on the control group were 1.6% more likely to get an NV-HAP than the patients on the intervention unit. These patients were considered independent with care by day 1, typically after surgery, and this may have contributed, I believe, to the reduced results, because people who are independent are sometimes not necessarily assisted as they might need to be, because we just consider them fully prepared. However, also, they had an additional risk factor of being of increased advanced age and a longer length of stay, which are both risk factors for NV-HAP. The complete oral assessment and swallow eval was the first step of the oral protocol. Next, there was 4 different protocols designed with an actual provided amount of equipment and steps to be taken by the practitioner and frequency. There was a hope that they would do oral care 4 times a day. Unfortunately, neither study group ever achieve that. So the study was not able to report on what is optimal for oral care. And I think the knowledge that some patients can expectorate and others can't, and this poses a really significant aspiration risk for these patients who can expectorate. And I thought that that was really clinically pertinent to us nurses who are assisting people with oral care all the time. And one of the other things that really made a difference in terms of improving the adherence to oral care was the provision of the correct equipment for the correct need. And it costs money to do those things, so there's a lot more in this situation than first meets the eye. I appreciate you taking the time with me today, and thank you.